Pneumothorax, patients with pneumothorax, remember that it is a lot of air trapping. So even though there's a lung collapse, there is air trapping as well, okay? So of course, when you're going to tell the patient to breathe, you're going to see unequal chest expansion on the area that the lung is collapsed. Patients will come with tachypnea, tachycardia. In addition to that, the patients can have cyanosis, they can have use of accessory muscles, palpation, the tactile fremiters. Remember, they fly, but they tend to fly not as well as they walk, so that's the reason why they tend to be decreased. Now, when you have a tension pneumothorax that the entire lung is collapsed, it's not going to be decreased, it's going to be completely absent, okay? But most commonly, the tactile fremiters is decreased when you do not have a tension pneumothorax, okay? So if you do have a tension pneumothorax, of course, the mediastinum shift to the contrary side as well as the trachea. You can see that and you also can palpate that. Because there's a lot of air trapping, remember that when you percuss, the air sounds loud. So there's hyperresonance to percussion. And in auscultation, of course, the breath sounds are going to be diminished or abolished. Asthma, this is no more than a hyperreactive airway disease. Patients with asthma also come with dyspnea. They come with tachypnea and tachycardia. They can also use accessory muscles. So you can see that in inspection. In palpation, remember the voice, the fremiters, they decrease in air condition. And when you do percussion, there is hyperresonance because there is air present, okay? And in auscultation, of course, they're going to have decreased breath sounds and expiratory wheezes. So, again, what is shortness of breath? It's no more than a sensation. This is basically subjective, even though you might see patients are completely confused and they cannot even talk to you, but you could see the accessory muscles be used or abdominal breathing type, okay? Causes of shortness of breath, well, any acute or chronic condition at the level of the lung. But remember, shortness of breath is not only limited to lung diseases. Shortness of breath patients with damage of the brainstem can also have shortness of breath because the respiratory center is located at the level of the medulla and the palm. So any damage at this level, patient can come with tachypnea or with different type of pathological breathing patterns that we already have discussed, and they don't have anything in the lung. In addition to that, remember that patients can come with tachypnea due to a compensatory mechanism of metabolic acidosis, and the patients have nothing in the lung, okay? But if we go through the process of acute dyspneic episode, remember that pulmonary edema tend to be cardiogenic or non-cardiogenic. Cardiogenic pulmonary edema, this is highly present in patients that have congestive heart failure, mostly left heart failure, or any type of left-sided valvulopathies, that there is the backup of fluid in the interstitium of the lung, producing not only inspiratory crackles, but as well congestive changes at the level of the chest x-ray, and the patients do come with shortness of breath. Patients with asthma tend to have dyspnea because there's hyperreactive airway disease producing bronchospasm through aspiration, so the expiratory phase is prolonged, and that's the reason why the patients come with shortness of breath. If you have any type of chest wall injury that have chest contusion, there's hematomas or damage at the level of the intercostal muscles, or you can have a contusion at the level of the intrapulmonary parenchyma impeding appropriate chest wall expansion. The pain itself can produce shortness of breath. Pneumothorax, a collapse of the lung, either spontaneous or traumatic or iatrogenic by procedure, such as thoracentesis, can also produce shortness of breath because the vital capacity is limited. Patients that have a pulmonary embolism, this is no more than a shunting mechanism, or dead space mechanism, that even though there is the normal gas exchange at the level of the alveoli, the capillary is obstructed by a clot, so that therefore impeding proper ventilation, and the patient comes in with shortness of breath. Pneumonia, this is no more than an infiltrative process. This is an infectious process that produces that consolidation at the level of the focal area of the lung in one lobe or multiple lobes, and that impedes gas exchange. Adult respiratory distress syndrome most commonly is because there is collapse of the alveoli produced by lack of pneumocytes type 2 due to a severe inflammatory process. Pleural effusion in patients that have fluid accumulated in the lung that decreases vital capacity and tidal volume, as well as this effusion could be an empyema, it could be a pneumothorax as well. Okay? So chronic progressive disease is in patients that have chronic obstructive pulmonary disease. This is no more, remember, chronic bronchitis with emphysema and either rupture of the alveoli, impeding gas exchange, or patients that have a massive amount of sputum production being accumulated at the level of the bronchioles, impeding expiration. We talked about CSF, patient with interstitial pulmonary fibrosis by any kind. Patients can have severe inflammatory process, idiopathic or autoimmune conditions, or patients that have pneumoconiosis exposed to fiberglass or asbestos or wood or painting, and that produces several scarring processes at the level of the lung, producing a rigid lung and impeding a proper inspiration. And that produces shortness of breath as well. We talked about asthma and pleural effusions, and we talked about thromboembolic diseases. Psychogenic dyspnea, patients that have panic attack. Patients tend to have hyperventilation and respiratory alkalosis, and that impede gas exchange as well. Don't forget about anemias. Remember that patients can have anemia and have shortness of breath and nothing in the interstitium of the lungs, so the lungs could be completely normal and clear, but remember that the hemoglobin transports the molecule of oxygen, and that's the reason why the body tries to compensate, not only by producing large amounts of erythrocytes, but in addition to that, to increase the respiratory capacity of the patient to increase oxygenation, okay? So please, whenever you receive a patient, concentrate on the conditions that can have an emergency first, and then you can feel more comfortable treating the chronic conditions after. So try to rule out a possible foreign body. Most likely the patients would not be able to talk properly, they will be drooling, they would have stridor, they can't cough properly. Patients that have any type of asthma episode, like status asthmaticus, that they have a lot of expiratory wheezings. Patients with a pulmonary embolism, the most common presentation is tachypnea, even though they tend to have also pleuritic chest pain. And remember the virtual triad to rule out the risk factors for thromboembolism. Patients with pneumothorax, suspect this in patients that have, for example, emphysema, or patients that have Marfan syndrome, a collagen disease that basically produces repetitive lung collapse. In addition to that, suspect this in patients that have had traumatic chest injuries, patients that have recently had a procedure on the chest, such as thoracentesis or pacemaker implant, or a portocath, or a central line being inserted, or patients that have been on the ventilator with high PEEP. So suspect a pneumothorax on those patients. Pneumonias, patients that have fever, chills, been exposed to upper or lower respiratory infections, has traveled outside the country. Patients have sputum production, greenish, yellowish, or gray color. And heart failure, patients tend to have a history of congestive heart failure. You can not only look at the chest x-ray, the patients tend to have pulmonary edema, but you could do an echocardiogram and validate poor ejection fraction or any type of left-sided valvulopathy. So we went through all the symptoms that are most relevant in pulmonary. and we're going to develop case studies for you to practice. And this is the end of this presentation.